And you said that the guidelines had changed, and that was back in 2021. The U.S. Preventative Services Task Force changed the age at which they recommend screening begin from 50 to 45. And why is that?
Yeah, so that's a really great question, and a big part of the research that I'm engaged with as well is that we're seeing more and more young onset rectal cancers, colon cancers and rectal cancers, but especially rectal cancers.
Thank you, Michael White, Dr. Michael White from MD Anderson, colorectal surgeon, associate director of research in the Department of Colorectal Surgery. I'm very excited to talk to you about colorectal cancer.
Yeah.
So first off, let me just sort of tee it up. Colorectal cancer is the third most diagnosed cancer in the U.S., the third deadliest, kills over 50,000 people per year. So today we're going to talk about, sort of the pathogenesis, how it develops from a little, the single cell all the way up to a cancer that can kill somebody, and then go through prevention strategies, screening, and sort of related topics. But before we get started, why don't you just start by telling everybody about yourself, where you're from, and how you got interested in this field?
Yeah, absolutely. So I'm a surgical oncologist. I trained here at MD Anderson for my fellowship, and really became interested in the surgical management of metastatic colorectal cancer through that fellowship training as well as my residency training. I found it a really interesting field because we know how to treat localized colorectal cancer. We know how to treat colon polyps very well. But the management of actually metastatic colon cancer is difficult, and metastatic colon cancer is what's going to kill the majority of patients with colorectal cancers. And so the surgical management of that is something I was always excited about because it's such an unknown in the field. So I had the opportunity to join the group here at MD Anderson about 3 years ago, and I have a practice taking care of patients with peritoneal metastases from their colorectal cancer. As part of my practice as well, I have about a 75% research effort, and we're interested in studying the role of both the gut as well as the tumoral microbiome and the bacteria that live within these colorectal cancers and the impact they have on outcomes as well as the development of colorectal cancer itself. And as such, a lot of interest in environmental factors and their role in the development of colorectal cancer and its progression.
So why don't you start by telling everybody, colorectal cancer is similar to other cancers in that it develops from a single cell that acquires mutations that allow it to grow uncontrolled and then to spread. But just maybe it's unique from some other cancers in that there's a pre-malignant lesion. And can you talk about that?
Yeah, absolutely. So our understanding of the way that colorectal cancer develops, as you mentioned, is that essentially a polyp will form, and as these polyps progress over time, they're able to demonstrate new mutations and more progression and greater virulence. That then develops from a polyp to high-grade dysplasia to a colorectal cancer itself. And then that colorectal cancer can then develop the potential to metastasize more distantly. These colorectal cancers can cause issues with intestinal obstruction, but more oftentimes pose a risk to patients when those metastases continue to progress to other sites of disease. As far as it being unique from other types of cancers, it is probably the best studied and the best understood as far as its progression from a polyp into a malignancy. It's a very well-defined progression for what we think of as canonical colorectal cancers. And that's led to a lot of screening recommendations and our ability to catch colorectal cancer even as in its polyp form or in its early stages and intervene before it causes symptoms and problems for patients.
So speaking of that, so you mentioned obstruction, and a patient with bowel obstruction might experience abdominal pain, maybe if they're getting septic, fevers, have some other signs. What other kinds of symptoms can people with colorectal cancer demonstrate?
Yeah, those symptoms that you mentioned and that I mentioned earlier are really sort of late stage symptoms. And that's one of the really difficult things about colorectal cancer is oftentimes it can progress and even metastasize without having any real symptoms that patients will notice. One of the major things that we see are that patients will complain of blood in their stools as an early sign of colorectal cancer or a polyp that's causing some symptoms. There's a lot of reasons for folks to have blood in their stools, but it's certainly not a symptom for anyone to ignore. It's something for them to talk to their doctors about if they do notice it. But that's really the difficult thing, and what really underscores the importance of surveillance, because we see that these colorectal cancers can develop and progress so extensively before symptoms really develop.
So that's a good segue into surveillance and screening. I think the problem for a lot of patients is that, they feel okay. They feel like, I have no symptoms. Why should I get screened? Screening, with colonoscopy, which we'll talk about, there's a lot of prep involved, which, as anyone who's gone through it can attest to, it's very, uncomfortable. I have not, fortunately, yet had to do that, but, in terms of just sitting on the toilet all day and then having to be put out for the procedure itself and any risks associated with it potentially. Can you talk a little bit about screening? How many people are getting screened? Like, is everybody who should be getting screened, or are there some people who are skipping it and potentially at risk?
Yeah, so the screening recommendations have been updated recently, and there's a number of bodies that have different screening recommendations, but largely we recommend that folks at the age of 45 start getting screened with colonoscopies, and then based off of that, the the interval of surveillance can be adjusted based off of what that patient's polyp burden looks like. I think it's one of those things that we as physicians, it's very easy to say that you need to get a colonoscopy at 45. It's something else to say that you need to spend an evening doing a bowel prep, and then you need to spend a day off of work. You have to have a loved one come and drive you home from your colonoscopy. And so it's a big input for the patients as far as their effort. And a lot of patients have trouble getting to their colonoscopy. And so we see that even though we have these very strong recommendations for colonoscopy, that a large proportion of patients in the community just simply aren't receiving their regular colonoscopy despite those recommendations.
And you said that the guidelines had changed, and that was back in 2021. The U.S. Preventative Services Task Force changed the age at which they recommend screening begin from 50 to 45. And why is that?
Yeah, so that's a really great question, and a big part of the research that I'm engaged with as well is that we're seeing more and more young onset rectal cancers, colon cancers and rectal cancers, but especially rectal cancers. The reason for this increase in incidence is unclear, but it's a really alarming trend where we're seeing decreasing incidence in colon rectal cancers in older populations as screening is successful in treating the polyp burden in the community. We're seeing more and more of these early onset colorectal cancers, and that was why the U.S. Preventative Services Task Force pushed that age recommendation back to a younger age. But we really need broader screening guidelines, because seeing patients in their 40s and late 30s and even 20s is not uncommon for us. And those are patients that aren't getting screened and aren't having their colorectal cancers detected and potentially intervened upon. And we're finding that those younger patients, that when they come in, have more advanced disease, and it's likely because they're developing these colorectal cancers before they get before they reach that age of screening guidelines.
So MD Anderson is a very special place in that it's, basically the best cancer institution in the U.S. and arguably in the world. And that's just straight up, looking at a number of different metrics. And so your patient population is therefore going to be a little bit different than maybe other people in the community are seeing.
Absolutely.
What is the youngest patient you've ever seen with colorectal cancer?
I've unfortunately seen, outside of, genetic syndromes like Lynch syndrome and FAP, where we see can see very young onset colorectal cancers, but I would say we see patients in their 20s and 30s, if not every week, at least every month in my clinic, which exclusively treats metastatic colorectal cancer. And
so again, 20s and 30s, you're seeing them, and sometimes not with just localized disease, but with metastatic disease.
Yeah.
That is wild. Why is this? I mean, so there's something going on, right? The age at which people are getting it is going down, and sometimes getting, advanced disease at these really young ages. What is it either about our environment, the food we're eating? What are people thinking is causing this?
Yeah, so that is a great question. It's actually one of the major questions of the colorectal cancer moonshot program that we have here at MD Anderson that I'm actually also a co-director of. The short answer is we don't know. one of our big hypotheses and is focus of the actually last year's moonshot was the impact of high fructose corn syrup in the development of colorectal cancer. In murine models, we're able to see that colon polyps develop more frequently and and progress more quickly to colorectal cancer in the presence of high fructose corn syrup. Epidemiologically, we are still putting those pieces together. That's one of those observations that's really important that we fully understand, because it's one thing to show this in a preclinical model. It's another thing to say that we need to impact our entire food supply chain. But that's one theory that's out there. Our group has also shown that the mutational profiles of these young onset rectal cancers are distinct from later onset rectal cancers. And my group specifically has recently shown that the bacteria that inhabit these rectal cancers is distinct in young versus late onset rectal cancers. And so we're seeing a lot of signs that the biology of these tumors are different, but we don't have a clear environmental cause, something that we can really point a finger to. But it's something that we're urgently looking at right now.
Yeah, wow. I'm glad that, there's so much attention focused on it, because it's such a public health nightmare. Like you said, the guidelines are so far behind what you're seeing clinically of, even these new guidelines of screening starting at 45 are not going to catch these people in their 20s and 30s. Mm-hmm. That's really fascinating, the potential connection between high fructose corn syrup and colorectal cancer. And of course, it's so ubiquitous. And, there are a number of reasons for that. Everything from, big agriculture, and subsidies mm-hmm. that are then flooding our food with these types of sweeteners, to a lot of other factors. But it's just, I guess, one piece of a larger puzzle. There's also, these chemicals, PFOAs, that are, made popular by movies like, what is it, Dark Water or something mm-hmm. with Mark Ruffalo, and some other movies where there's like the activist lawyer and they're fighting the big corporations. And, there are so many chemicals that, are not even regulated right now that are, in our food and our cookware, mm-hmm. That, maybe 20, 30 years down the road, we're going to find out, oh, this thing is ubiquitous and it's actually causing cancer. So I know how difficult that is to try to then, extrapolate, find, these molecules and demonstrate a causal link. Yeah. So, good luck to you guys doing all of that research. In terms of improving, survival, are there things that we can be doing at these young ages for the general population, not talking about people with Lynch syndrome, mm-hmm. who obviously they're high risk and we know they're high risk, but, for the general population at these young ages that we can be doing, maybe avoiding high fructose corn syrup or other lifestyle modification?
Yeah, I think we certainly see that there are lifestyle correlations with colorectal cancer. We see that, high-fat diets, a Western diet, obesity, alcohol consumption, smoking are all related to colorectal cancer when we look epidemiologically. And so I think it makes sense to do our best to avoid those things, both in our colorectal cancer risk as well as just our general health overall. And so a lot of the things that you would avoid for colorectal cancer, you would avoid just to lead a day-to-day healthy lifestyle, maintaining a healthy weight, avoiding some of these things that we know can lead to colorectal cancer, but can also lead to other health issues as well. I think one of the really important things to note too is that even though at a population level we can decrease that colonoscopy guideline, the younger age we put there, the fewer gastroenterologists we have to actually do these colonoscopies. They're intensive procedures. They take a significant amount of time and energy. And so it's really important that we develop new screening tests and screening profiles. And so when we look at other nations with more of a socialized healthcare system like Great Britain, they have fecal occult blood tests that are done on a national scale. And so I think examining some of those population level interventions is also going to be important to catch these colorectal cancers at an early stage when we know we can intervene and cure the vast majority of these cases, as opposed to when they present at a later stage with metastatic disease where cure is really difficult to achieve.
Yeah. I saw some statistic that, every year we spend somewhere in the ballpark of $730 billion on diseases that are considered largely preventable. But, less than 3% of the spending is actually on prevention itself.
Yeah.
And so it's one of those things like, what is the saying about a pound of cure is worth a teaspoon of prevention, something like that. I just butchered it, but if you have a finite amount of resources, where do you get the biggest bang for your buck? And it seems that prevention is the way to go, hands down.
Yeah, we unfortunately live in a very reactionary culture. We don't want to. It's really hard for us to deviate from our day-to-day life that we're used to. Until we see a real problem that's there, and I think that's just a fact of the culture that we live in, and hopefully one that we can continue to improve. I think there's more and more attention given to the sort of idea of leading a healthy lifestyle. I think the big thing that we're lacking is data and information about what that actually looks like beyond trends and popular thoughts and ideas. We really need. We need data, we need science, we need facts that we're working off of, not just trends.
Yeah. You had mentioned, so we had talked about colonoscopy, then you mentioned a fecal occult blood test. So maybe we should talk about, different screening modalities, unlike, some other things where, for example, for prostate cancer, PSA, at least right now, is sort of like it, and then there are some confirmatory tests. But in colorectal cancer prevention, there's fecal occult blood test, there's colonoscopy, there's some others. Can you sort of give us like the 10,000 foot view of those?
So, colonoscopy, certainly I would consider the gold standard for screening. But as I mentioned, the scalability of that to a global population rather than just an older population that's at higher risk for colon cancer is difficult. There are things like fecal occult blood test, which has its own issues and potential problems with it, but essentially looking for microscopic levels of blood in a patient's stool. And that can be done as a send in, send out test, so patients can complete that at home. And then there are some other tests that are becoming more commonly studied. Things like circulating tumor DNA has been looked at for colorectal as well as other types of cancer screening, where essentially low levels of DNA that we know to be pathogenic for specific types of cancers are studied in patients' blood. And so a blood draw is performed, and then this sort of ultra deep sequencing is performed to then look for specific DNA sequences that we know are associated with cancers. And then that can trigger more advanced screening like CT scans or colonoscopies for patients. That has been There was a recent New England Journal article, I believe, last year looking at that for one of these companies. That comes, of course, with the issue of false positives, where patients then have a positive blood test, no malignancy is found, and then that comes with a lot of anxiety, a lot of unnecessary medical tests, and the downstream effects of those. So I think that needs to be really looked at a population level before it's brought to the mainstream.
The idea of it's very exciting. Like it sounds so futuristic, like you draw somebody's blood and then you're finding these DNA fragments that are outside of cells, to be clear. These are not metastasizing cells.
Yep.
It's just the DNA floating out there in the blood. We're able to, run it through this sequencer and basically find these mutations that are associated with cancer. Not only that, but then based on the sort of number and the combinations and the locations of these mutations, to say it is most likely from colorectal origin or it's most likely from lung. And so, like you're saying, a lot of technical challenges with this. False positives are certainly a problem.
Yeah.
And then in terms of, with any good screening test, you need the sensitivity to be high enough. And a few other things, the incidence in the population you're studying needs to be high enough, and so on. I saw a statistic on this, again, a recent study, that the sensitivity for early grade cancers, which is what you want to find with this kind of a test, is something like in the ballpark of 27% right now. compared to colonoscopy,
Right.
which is, like you said, the gold standard, 95%, something like that. Maybe it would have some trouble seeing like a sessile, a flat polyp, maybe, or if there's a poor prep, maybe poor visualization. But in general, performs way better, at least right now, than the best cell-free DNA.
Yeah.
But is there a role for it, would you say, right now in certain populations, high-risk people, or?
I wouldn't say outside of a clinical trial right now that the cell-free DNA would be useful in screening a population for colorectal cancer or other malignancies. We do use it quite ubiquitously in the management of our patients, where we're looking to detect recurrences early and intervene on those patients sooner rather than later. That I will say, while we use it quite ubiquitously here in our group, that's a great area of debate. When we go to ASCO and these big national meetings, it's one of those things that gets debated on the main stage, and not everyone is in agreement that even that is ready for prime time, as one would say. But
yeah, I think healthcare right now, I mean, it used to be the culture was you just trust your doctor implicitly, and then we sort of moved to like, okay, I'll get a second opinion, and then we moved to like Dr. Google, and now we've moved to like influencers and people hawking like the newest, fanciest wearable, and these new sophisticated tests, whole body MRI. And so I think a lot of people listening to this and other shows, and they have their influencer du jour, hawk whatever product,
Yeah.
they're tempted to say, well, I'm going to take control of my health destiny. I'm going to, I don't care what my doctor said. I don't care about your numbers. I'm going to go and like get this test myself. Like, what would you say to those people?
yeah, I would say I actually have this conversation quite frequently as more and more patients, I think, especially the idea of ivermectin and febendazole and these antihelminthic drugs having anti-cancer effects. Actually, the last time I had a patient bring this up, I went to Google and I put it in myself, and I was actually really alarmed by what I found, that you don't find guidelines or recommendations from well-established cancer organizations or physicians. What you find are actually pretty fringe articles, even one written and published in PubMed, so it looks like it's from the NIH, which it is not. It was just published in PubMed and then is there. And you have to get to page 2 of Google before you actually really start to see some results that say this is not a proven cancer therapy. And when I do Google searches, I rarely go to page 2. And so it's understandable that patients feel that way. And I think it's distressing the how broken the trust is between physicians and their patients, frankly. That patients are going to Google and looking up these things and not listening to what their physicians have to say and what the data and research has to show us. And this is something that I would be, if anyone in the world is interested in how bacteria or other types of microbes are interacting with tumors, it would be me, right? That's sort of exactly what I study. And it frankly is just not, there's no strong data for it. And it can actually be harmful. We know that those drugs interact with oftentimes are some of the chemotherapies we oftentimes utilize. And it gives a false sense of security. And I hate to say that I've seen patients shun standard therapies that we know would work for them as they go along this path of following influencer culture. And it's more exciting to do that, but it's not efficacious. And so it really is disheartening, I think.
Yeah. Well, I'm glad that you're there to, you've actually looked into these things and not dismiss them out of hand. I think part of the distrust comes from like, oh, you're not open-minded. You're, stuck in your ways, and, you have this traditional thinking about medicine, and you need to expand your mind and open. So if you actually say, look, I've done a Google search, I've looked at what the evidence is that they're, putting forth the quote evidence sometimes, and it really doesn't stand up to scrutiny, then, hopefully you can win some of these people. I've had similar conversations, and, it's really sometimes disheartening, like you said, to see where some people go for their information, and show them like, look, this is actually a well-designed study here, and versus this is some guy's opinion, or it's extrapolated with some idea of mechanistic plausibility that, if you were to kill these bad bacteria or microorganisms, then it should, have this influence on the immune system or whatever. Like, yeah, like you can do that type of, logic, but in the end, it's really data that moves the needle. So
yeah, and the really frustrating thing that I find is that we actually know that there are bacteria in these tumors, and we can target those bacteria. And in preclinical models, we can actually improve cancer-specific outcomes by targeting those bacteria. But they're not anti-helminthic. It's a completely different pathway. And so I selfishly worry about the work that I'm doing and the work that other folks like Susan Bullman and Chris Johnson here at MD Anderson and Jen Wargo, that work that's very important is being clouded by some of these kind of fad treatments that get hawked, and it, more globally, just the erosion of the importance of truth and fact, I find really distressing.
Yeah. Let's shift gears a little bit and talk about prevention. We had talked about some lifestyle things, but in general, colorectal cancer, I think, isn't thought of as much like a preventable disease as like lung cancer, where it's very, the causal relationship between smoking and lung cancer seems to be pretty well accepted. There are some fringe people I have seen, again, online, who are saying, oh, actually, they're living longer in Sardinia because they're smoking and it's, helping their immune system or whatever crazy. But in general, people pretty well established or accepted that established link. But colorectal cancer, there are some things that we can do to decrease our risk. And, maybe just talk about some of those things.
Yeah. So, we mentioned sort of I think one of the strongest correlations that we see is the just Western diet and its association with the development of colorectal cancer. And that is oftentimes plotted as the amount of red meat consumption. Whether or not that's actually causal or a proxy for some other factor is really unclear. But we can see that in industrialized nations that the more red meat, the more fats and unhealthy fats that are consumed, the higher the rates of colorectal cancer. And while that's difficult to prove causally, I think it's a good marker to focus on a healthy diet to minimize, processed foods and red meats. I think certainly one of the other things that we see is that there's just not a lot of fiber in the Western diet as well. And we know that has a great effect on just overall gut health. And we've seen in work in melanoma that actually high fiber diets are associated with a more robust immune response to tumors and better response to immune checkpoint blockade. And so I think that all those pieces put together, the sort of common sense, moderation, and just thoughtfulness about what one is eating is probably the best thing for folks.
Yeah, I think, like you said, it's sort of hard to study this. Like you can't sort of put people in a building and just feed them from, when they're born to when they die, and then look at, people. So, people, when they sort of criticize the whole food plant-based strategy and, the criticisms of the Western diet in its role in colorectal cancer rates, they sort of forget that the accepted link between smoking and lung cancer, it also is based on these observational studies of, populations, and, nobody is assigning, okay, you're the 2-pack a day smoker and you don't smoke, and then see what happens in 20 years. And so, it's sort of a double standard, I think. But, for the number of studies out there, tons and tons of data on it, not only looking at the population of, this country versus that country, but also changes over time, that as, the diet changes in places like, in Japan, even in these blue zone places that traditionally had whole food plant-based diet, we're seeing, the Western diet sort of make its way in, and, it's thought that a lot of these places will no longer be blue zones because of that. Going back to, so the red meat you said, do we have any idea of what it is about the red meat versus, chicken or fish?
Yeah, there's things like short-chain fatty acids that we see are associated with colorectal cancer development, and so there's some thought that these Western diets increase the amount of short-chain fatty acids within the gut and can lead to colorectal cancer carcinogenesis and progression. But those are links that we still need to really understand and study, and we also have to remember that red meat consumption is likely also linked with high fructose corn syrup, for instance, right? And so which one of these factors
It's so hard to tease apart.
comes with the Western diet is really difficult. I do want to highlight work that's being done here at Anderson by Jen McQuaid and Carrie Daniel McDougall that are actually where they're able to affect the diet of patients that are undergoing surveillance for their melanoma, where they are providing actually high fiber diets for patients where they're providing all 3 of their meals a day and their snacks in between, and comparing those to patients getting a standard diet and dietary education. And they're able to demonstrate that they're able to increase those patients' fiber uptake and are actually seeing, I believe it was presented earlier this year, improvement in recurrence-free survival for those patients based off of their dietary changes. And so that really starts to lead to causal inferences. It's not just a correlation we're seeing, but if we can actually change the diet of someone and it changes their cancer-specific outcomes, then we're seeing that we're clearly able to make an impact and a difference, and we're able to delve into the fact that it looks to be the only thing that's being changed in those diets is really the amount of fiber that they're receiving. And so it seems like that fiber is important for the global immune function in an anti-cancer role.
Do we have any idea of mechanistically how the fiber is helping? I mean, we talked about the microbiome, good bugs versus bad bugs.
So observationally, when we look at patients that are naturally taking a high fiber diet, that they have a greater abundance of what we think of as good bacteria and a lower abundance of what we think of as bad bacteria in terms of their response to immune checkpoint blockade. And I should say this is in a melanoma patient population, but I don't think it's unreasonable to assume that the same types of pathways and anti-cancer effects are playing a role. And in fact, in some unpublished data that I probably can't go into the specifics of, we're actually seeing very similar bacteria play a protective role in colorectal cancer treated with immune checkpoint blockade as we see in melanoma. But we're seeing that there are a greater abundance of these good bacteria, lower abundance of bad bacteria. And when we look at the tumors in preclinical models, mice fed with a high fiber diet as compared to a low fiber diet have a much more robust and more active immune infiltrate within their tumors. And so the fiber looks to adjust to affect not only the microbes within the gut itself, but also the immune response to these tumors. And we know the importance of the immune system in its response to both anti-cancer surveillance as well as suppression of metastases and progression of cancer.
So when I was at your house, I saw a little bag of fiber powder.
Yeah.
And I looked on the back, and it looked good. It looked like good stuff. It had soluble fiber, insoluble fiber.
Yeah.
You said make yourself at home. No, that's the only thing I was, and the piano.
Yeah.
But aside from that, I didn't do any snooping. But so, can people just sort of take more fiber in the form of supplements? And is that basically enough to be protective? Or is there other stuff in the food that tends to have high fiber that is beneficial?
So great question. So we know that our guts are built to have much more fiber than we're seeing in a day-to-day basis. And so I think supplemental fiber is actually a really important thing for just about everyone, unless you are a vegan that focuses on high fiber foods. We're just simply not getting enough fiber, and for our day-to-day gut health, I think it's really important. We don't see the anti-cancer benefits that I mentioned just from supplemental fiber itself. And it seems like fiber actually built into our food sources is what is important. And so plant-based diets, focusing on high fiber foods like fruits and vegetables and whole grains is really something that's really important. We recently, and we're in the process of working on a study where we looked at employees here at MD Anderson. We started this during the COVID pandemic, but we looked at employees and what their dietary patterns were, and we looked at if the amount of fiber intake was associated with their tighter response to either the flu vaccine or the COVID vaccine. We haven't shown that link yet, but I was very proud that I had the highest fiber intake of any of the employees.
Hey.
In the
Good for you. Wow.
Yeah. So, yeah, I think it's something that's important, and I think it's good for our general gut health. I started honestly taking supplemental fiber when I was doing my surgical residency, and I saw enough benign anal rectal disease that could have been completely prevented with high fiber diet or supplemental fiber that I just started taking it on a day-to-day basis.
Benign disease meaning hemorrhoids or?
Hemorrhoids, anal rectal fissures, fistulae, things like that.
Wow. Yeah, I mean, from the straining, I mean, there are other things like varicose veins of the lower extremity, hiatal hernia, things that, are just pushed in either direction, I guess, by the increase in intra-abdominal pressure. But yeah, that's so right. I mean, just even thinking of things beyond colorectal cancer, just a lot of benefits with fiber. Yeah, and again, like fiber intake, it's one of these things that like something like 90% of the U.S. population does not get the recommended amount.
Yeah.
It's just really incredible. So yeah, I think for probably most people listening to this, it would be a good idea to supplement. And do you have any recommendations of types of fiber, soluble, non-soluble, different sources?
I think the best supplemental fiber, if it's something that your physician also recommends, is the supplemental fiber that you're going to take on a day-to-day basis. So for some people, they're only going to take a gummy. I don't know that helps all that much. Metamucil is probably the most common one that is, has a high fiber source. I take something called Consul that I think has the highest sort of fiber concentration. It's not a fun thing to take. It usually takes, there's sort of a week or two that you're going to feel a little bit uncomfortable and bloated as you're taking it, as your gut gets used to seeing the amount of fiber that it really should. But it's something that will ultimately pay dividends down the road, I think.
And that discomfort is something that also when people are making a dietary change from, omnivorous to, a whole food plant-based diet, and their amount of fiber like quadruples or quintuples, that they do have gastric distress. And that is one of the things that for somebody who goes sort of, cold turkey from meat, they can really have some upset, flatulence and frequent bowel movements, and sometimes that causes them to actually stop the diet altogether.
That was one of the biggest problems that Dr. McQuaid and Dr. Daniel found in their feeding study of high fiber diets, was that the biggest complaint was the patients were having sort of GI upset and distress as they weaned onto the high fiber diet. And some patients, I think one or two patients even gave up the diet based off of it. But.
Yeah. I think for that reason, I mean, when I talk to my patients, I say, okay, this is where you are, this is where you want to be. Let's make these incremental changes. And, it might take, as your microbiome changes, as the gas producing organisms get balanced out by gas consuming organisms and so on, and your body sort of adjusts to it, then you can scale up the amount of fiber. Yeah. But yeah, unless you want those symptoms and you're, maybe you work from home and you're flexible and you can like run to the toilet whenever you need to, like, it might be better to sort of take it slow for the long-term, benefits. But are there any other things that we can do to decrease the risk of colon cancer?
Certainly smoking is something that's been tied pretty heavily to colon cancer. There's a lot of reasons to not smoke. But we oftentimes think of lung cancer and its association with smoking, but we forget about the associations with pancreatic cancer, with colon cancer, and these GI malignancies. And I think we can't overstate the harm that smoking does. Listening to another podcast, I think Institute for Moral Ambition is a recently started group, and they went through and looked at the most preventable health, or I think even just globally, the most impactful thing that they could do, and it was actually smoking in Europe, because it's so ubiquitous there. It's so obvious that it has these negative health benefits, and so that's one of their big projects. And the founder of that group was, I think, interviewed on the Daily from the New York Times recently. It was a really interesting interview to hear.
Nice. Yeah, I mean, smoking, you think about it, like the smoke goes directly into your lungs, but of course it's all the chemicals in the smoke are touching your mouth, you're swallowing them down. So we see a lot of oropharyngeal cancer, esophageal cancer. So yeah, basically anywhere where you can imagine those chemicals, as well as the inflammation to your whole body that can lead to cancer, basically anywhere, the pancreas. So yeah, really great point about that. Going back to diet,
Yeah.
milk, dairy products, I find very fascinating
Mm-hmm.
because on the colorectal side, it's actually been found to be protective.
Yeah.
But then, my work that I did before on prostate cancer, my counseling would be that it probably does increase the risk.
Yeah.
And so, there are a lot of conflicting things out there, when you're looking at the data of certain things. And sometimes it's because there's a well-designed study versus not well-designed.
Mm-hmm.
But in this case, it's like one kind of cancer versus another, and,
Yeah.
that there's some trade-off. Do you have any thoughts about dairy in general?
I think my main thought, especially when we have conflicting data like this, I actually have two main thoughts. One is that I just try to focus on moderation for all of these things, right? Like if you're taking in a lot of dairy, you're probably increasing your prostate risk more than you're helping any of your colorectal cancer risk. And so we've evolved to the point that we're going to see some dairy in our diet, and that's certainly something that's acceptable. And I also always try to, if you took cheese away, right, that's something that you gain pleasure from. That's sort of the point of being here, right, is to have some joy to your day-to-day life. And so taking that away is never something I recommend. And then in your point about how we designed these studies really reminds me of a grand rounds that my old chairman, Jeff Matthews, gave about truth and truthiness, and how you can essentially force the outcome of a lot of studies based on how you design that study and how you look at it and how you measure things. And so I would just sort of lean into that point too, that you really have to dive into these studies, especially these epidemiologic studies, and understand how their data is gathered, how they're analyzing that data, and what their potential conflicts are, especially because so many of the dietary studies are actually funded by food processing groups and things like that. So
Yeah. So a whole bunch of things. I mean, so being able to evaluate the data methodologically, as a layperson, obviously is very difficult. And then the interest. So who is funding the study? And it's been shown in a number of different spheres that if industry is funding a study, it's much more likely that their findings are going to be favorable to that organization. So that's something to also take into account. Great points. Other things, I guess, other foods that I just wanted to talk about real quick. So, some foods specifically, aside from just high fiber plant food, turmeric, onions, garlic, red pepper, that have been shown to, improve your odds of getting colorectal cancer. Any thoughts of those?
No, I think those are all interesting. They're all interesting. I don't really know what to make of a lot of them. I know one of my colleagues actually takes turmeric on a regular basis because he's been somewhat convinced by those studies, and he's seen some of his patients that take turmeric have some efficacy, but that's all anecdotal, and I think one person's decision and plan. So
yeah, I think turmeric is one of those, like you were saying, like an anti-colorectal cancer diet is like an anti-heart disease, and I think a lot of these things, like turmeric in general, just like has a whole bunch of health. It's of all the spices, it probably is the most like well studied, and even the extract curcumin has shown some benefits, and so that's like one of the only supplements that I'll actually recommend people take on a daily basis if they're not cooking with the turmeric. Then taking a high bioavailability form of that, just for everything from inflammation, musculoskeletal pain, so on and so forth. Some interesting sort of preclinical studies on foods. There's one that maybe I'll link if I can find it, where they just literally took the foods and like ground them up and exposed them to different types of cancer cells and showed their anti-cancer activity. And the allium family, the onions and garlic, seem to show some promise in a number of different cancers. So it's just interesting.
And those are all interventions that I think they're very low risk, right? Those are parts of our diet anyway. And so I certainly have a little bit more leeway to try to make those interventions. And, if I'm going to cook differently, as long as it's something that I was probably going to cook anyway, right? I think it's much more reasonable to make those types of changes than some of the other changes where there's a maybe equivalent amount of data, but it's a more significant change that one is making. And I would just love to see more research in the space of sort of impact of diet. It's just such a hard thing to study, as you mentioned earlier, and there's so little impetus and push to study it, because ultimately you're, at the end of the day, the most you're going to do is make some recommendations that people are going to be kind of upset about because you're changing their diet, and that's such a personal thing to people.
Yeah, and especially online,
Yeah.
Nutrition is such a, a dangerous space to get into. I mean, people have really strong feelings about it in a number of ways, and usually, like, the stronger they feel about it, like, the less they know about it. And
Yeah.
so you really, it doesn't lend itself to, a conversation like, well, look at this study. Well, look at my study. It's usually like, you don't know what you're talking about.
Yeah.
And,
It just ends up with people yelling at each other about beef tallow, right? It's
Yeah.
just,
Oh my God. Yeah, exactly.
yeah.
Oh man. So yeah, I think this is probably a pretty good place to wrap up. But I do want to ask you, you're, again, associate director of research at in the colorectal cancer department here at MD Anderson, and top cancer hospital. You sort of see all of the new research coming out. What is the most exciting thing to you in terms of things that could practically change in the next maybe 5 to 10 years? The either burden of disease or survival or anything related to that?
Yeah, I think I will start by saying I definitely have a slant toward focusing on patients with metastatic disease. And I think a lot of our conversation is focused on prevention and maybe early stage disease. But my real passion is, how do we treat and cure these patients with metastatic colorectal cancer? And the thing that I think is most exciting is that we're beginning to see some signal of response to immune checkpoint blockade, not only in what we call mismatch repair deficient colon cancers, but in mismatch repair proficient colon cancers, which typically did not respond to immune checkpoint blockade. And I hope that we're really just starting to see the beginning of a landslide of better, more tolerable systemic therapies, because I think that even saying this as a surgeon, the way that we get to cure for these patients is improve systemic therapies, and that surgery, what we want to do is just clean up the sort of mess after a systemic cure has been achieved, whether that is, removing a few nodules or taking out a stricture. Those are the patients with metastatic disease where I think we have the most hope for cure. And so I really hope that the signal we're beginning to see is real, and that we're maybe into a new sort of class of therapeutics that's going to really benefit the vast majority of patients with metastatic colon cancer.
I think advanced stage disease requires its own episode, and I'm super excited. Like, I definitely want to get into all of these things, because it, like you said, it really has the potential to change the sort of outlook, of patients even diagnosed with advanced disease, which used to be a death sentence. So really exciting stuff. Well, Dr. Mike White, I just want to thank you for being here again. And, I really wish you the best with all of your research, and hopefully we can talk again soon.
Yeah, absolutely. Thanks for the opportunity.
All right. Thank you.
Great.